Good afternoon and welcome to the CIO's Interoperability Agenda, creating an ecosystem of frictionless care, a health system CIO Media Inc. production sponsored by Philips. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO, and I will be your moderator today. We're looking forward to audience participation. You can use the Q&A box to send in your questions or comments at any time, and we'll take them later in the program. We're also going to do a little poll that we really enjoy here, get your opinion on a particular issue, and then have our panelists guess at the results. Just so you can get your screen into a nice mode here, first click on the top center, get it in side-by-side mode. Then you can adjust the divider so you get the video boxes and the slides the size you want. And it should say speaker view in the top right-hand corner. And so you see how we're going to spend our time today. First, we're going to go 35 to 40 minutes with our main panel discussion featuring Dr. Stan Huff, CMIO at Intermountain Healthcare, Dave Cassel, Executive Director with Carequality, and Greg Fulton, Policy Lead, Chief Medical Office with Philips. So let's jump right in to our discussion. Stan, let's start with you. Can you give us an overview of Intermountain and your role?
So Intermountain is a not-for-profit charitable healthcare provider organization with 22 or 23 hospitals centered in Salt Lake City, but now spreading out about 40,000 employees, and I'm the Chief Medical Informatics Officer.
Very good. Thank you. Dave?
Sure. So I head up the Carequality initiative in Health IT Interoperability. Carequality is a nonprofit serving the public interest. We're not a trade association or any other type there. And really our specific role within Health IT Interoperability is to take the work that's been done by lots of different networks and platforms and HIEs and vendor-based initiatives and sort of stitch them all together. And you can think of it as being not unlike what's done in the telecom industry by cell phone networks, where you as a consumer pick up a particular service provider, whether that's an AT&T or Verizon or what have you, but then you simply make phone calls and it just works. But it works because behind the scenes, there is a framework for how those different folks all connect with one another. And Carequality plays a similar role in Health IT Interoperability, connecting your Epic networks to Commonwealth, to the eHealth Exchange, to regional and state HIEs and so forth.
Very good, Dave. Thank you. Greg?
Hi, everyone. Greg Fulton here with Philips. In context for today's topic, I will describe Philips as a parallel track model approach to healthcare delivery in two ways: hospital to home and connected care. So meaning in hospital imaging, centralized ICU, sometimes called EICU, tele-ICU, precision diagnostics, image-guided therapy. Some could be outpatient, that hospital setting. Then you move over to a population health management platform that we also have that can integrate with EHRs in a health system. There come your analytics, there comes your care gaps, there comes your data aggregation. Move into the home, devices, remote patient monitoring, devices like that. So that's the connected care of getting that data within and without is really the approach that Philips is going right now. More specific to today's topic, happy to say in front of Dave Cassel, Philips is a member of Carequality, working on an imaging pilot there. We are also a member of the Commonwealth Health Alliance, and we've recently tested onto the eHealth Exchange. So investing in all of those networks and governance attitudes there. My role, briefly, I do lead policy around interoperability. I spend a lot of time with our industry relationships, as well as that with ONC, which has authored this information blocking regulation, as well as CMS as they continue to move up some of their interoperability payment models and this latest interoperability and patient access rule. So I do our comment letters and try to engage with these agencies, things like that. And I'll stop there.
Thank you, Greg. All right, Stan, we're going to start with you. Let me get through this question. What is the potential impact of the latest CMS and ONC interoperability regs on healthcare innovation and transformation, especially in light of the COVID-19 situation? What are some challenges you've been experiencing trying to comply with these new regulations?
So we're still working on it. First thing is, in light of COVID-19, what I can say is things are changing a little bit, but I would say for the last 6 months or more, the top IT activities have all been COVID related. Support for our remote specimen collection areas, reporting activities. Reporting activities, by the way, I mean, we're talking about interoperability here, and it's so disappointing in terms of public health reporting. So Intermountain, last time I checked, which has been maybe a month ago, so it might have changed a little bit, we had 13 different places where we needed to report, COVID activities, either testing results or how many hospital beds were occupied or how many respirators we had. And we have the local health department, the Utah State Health Department. Then there's the Vice President Pence's COVID tracking activities, the CDC, and the way that the data is sent is different in all of those environments. The only ones that are trying to use anything standard are the State Health Department and the CDC, and the other things are, all the way from spreadsheets to emails. We are not interoperable in any sense, and I hear everybody saying now we need to work on interoperability so that, whether it's the next phase of COVID or it's the next phase of or another pandemic, we're ready and we can share data. But I fear that it's going to be like the guy with the leaky roof. And they said, well, why is your roof leaking? He said, well, when it's raining, I don't want to get up there on the roof. And when it's not raining, my roof doesn't leak. I think they'll forget that we're not interoperable, and we really need to invest in it, and we need to be thoughtful about it, but I worry we're going to have a short memory. So anyway, that's a little bit. Complying with the regulations, actually, I'm excited about the regulations in the fact that it makes requirements that the systems need to be more open, and we need to allow patients and providers true access to the information they need to take good care of patients. We're working right now that it's fairly clear, and we've done a lot of preparation for the regulations that apply to our insurance group, Select Health. We're working still on what it means for clinical care and how we access and how we could allow a patient to use an application that they want to go ahead and attach to fire services. The technical part of attaching is one thing, but then sort of the policy and the process work. How do we know somebody wants to connect, and how do we give them permission to connect? How do we track it and make sure that it's not going to cause performance problems with the organization, et cetera? And we're working through that. It's surprising to me that there's that you look at the publication and then there's not like a bullet list that says you need to do this, and this is the date when you need to have it done. There's 1,200 pages of stuff there. It's kind of hard sometimes to see what all of the parts are. So that's maybe one of the challenges, is just making sure we know exactly what it is we need to do.
Are you seeing challenges in, you're supposed to share data right? And you're supposed to make data available to patients. I think you touched on this, the idea that you have to make sure you know where it's going, and you have to make sure you're authorized to release it to any third parties that the patient may want it to go to. You may make a mistake there. That's a huge problem, right? You've exposed their data. You've sent it to the wrong place. So you're trying to do the right thing, but you better get it right.
Yeah, no, absolutely. I mean, we're not doing it yet. So, but that's exactly what we're worried about.
Yeah. Okay, Greg, your thoughts?
Yeah, to Stan's point, I'll throw up a flare that right now health systems are looking at a timeline deadline of November 2nd as to when patients can approach and can request this data set known as USCDI. Agree, Stan, also, if you look at the CMS and the ONC regulations, where are they aligned? Patient access, CMS around payer data, claims, ONC, clinical, same FHIR standard, same. As to patient apps and API third parties, you probably well know this, but keep in mind too, once that data leaves your system, goes into the patient's app, it's no longer HIPAA compliant or no longer covered by HIPAA when that data leaves you. It is worth some outreach to the patients. There is some authentication you can help them with, or some outreach to patients by saying, well, does your app have a privacy protocol? Do they attest to it? So I think there are some things you can do to reach out to patients to kind of get them to where you're both comfortable with where that data is going in terms of third-party apps and things like that. We'll also agree with Stan. I truly believe, as I think you're implying, that if these regulations and rules go well, that's great. Could then interoperability really become part of an important aspect of public health? Could interoperability become a public trust? Shouldn't it be baked in? Shouldn't we expect it? I think that's where we really need to go. And I think innovation, you mentioned innovation in this question. I think the innovation is around collaboration. Innovation is around willingness. Innovation is around willpower. We stood up some things in COVID that were stood up fairly quickly and in scale in Brazil, Netherlands, the US, around monitoring and patient tracking and things like that. The technology is there. I think, again, Stan, you're right. It's the willingness or the collaboration to really overcome some of the technical specs or some hesitations there.
Greg, you mentioned patient outreach and education. I think you're talking about trying to help them understand the implications of releasing data to third parties and exposing themselves. But you also made the point that once, let's talk about health systems. So once the health system sends the data to a place it's been authorized to send the data to, and that's all done correctly, it's out of their hands. So you're almost talking about an additional service almost to do the right thing, even though health systems aren't responsible once it goes wherever it's been, they've authorized it to go. You're saying it's kind of the right thing to do to help make sure your patients understand some of this stuff?
Yeah, and in terms of, hey, if you want to come and request your data and you have an app, does it have a privacy protocol? Can it authenticate that it does? Can it attest to it? There is some language within the regulation that speaks to some things like that providers can do. I think that's going to help with patient retention. If you look at the run up to the regulation, I mean, CMS and ONC officials were saying publicly out loud on stage, well, health systems are the data hoarders. They don't want to lose patients. That's why we need this regulation. Fair or not, real or not, that was being stated. So I think it is a way to really get your patients comfortable with what they can do, because you don't want to be accused of being an information blocker. You don't want to have a complaint in the ONC portal. You don't want to have to deal with that. And really, patients understanding the process and how you can sort of guide them can maybe help avoid some of that.
Dave, lots of stuff there. Take it wherever you want. Lots of stuff to react to, the main question, whatever you want to go.
Yeah, there is certainly a lot to react to there. I think just to build a little bit off of what Greg just said, one of the the areas of work that I've been involved in, not directly related to Carequality, has been the work of the Karen Alliance, and specifically in developing what they call their code of conduct. So as you're looking at those patient education efforts, the Karen Alliance, it's CARIN, the Karen Alliance Code of Conduct is something that you could potentially encourage patients to look for in terms of apps actually attesting to it. Excuse me.
And go ahead.
Oh, yeah, no, sorry, go ahead.
No, I was going to say, just your thoughts around obligation, let's say requirement versus trying to go beyond the requirement, right? You may not have to do this type of education, but it could save you in the long run, because even though you did the right thing as a health system, if something goes wrong with that third party, the perception might be that it would somehow on you as well. So we're trying to avoid all that. Does that make sense? Am I seeing this right?
Yeah, I think you are. It certainly makes sense to me that you know, obviously there's only so much that you necessarily should invest in this. There's a balance in everything, but at the same time, providing your patients with some guidance, you know, regardless of what you're required to do, it is likely going to be beneficial for you in the long run in a number of areas, and you know, both some direct savings, if you will, in reducing the risk of information blocking claims and lawsuits if something goes wrong. Whether or not you can actually, you know, the lawsuit ends up sticking, you still would potentially have to deal with it in these sort of worst case scenarios. Mm-hmm. The mention of information blocking, though, is interesting, because as I think about the rules as a whole, I think that's the one where there's going to be a significant impact, and there's probably the most uncertainty, at least in my view, on exactly what that impact is going to be. We've talked here about patient apps, and they certainly are one of those parties that is often referenced in the information blocking context, but for me, I'm just have a cynical viewpoint, but I'm expecting the rule to be weaponized. I think it's going to happen, and a lot of the impact, and whether it ends up being positive or negative, I think is going to come out of who is actually making accusations and against whom. You know, is it going to be the app developers accusing vendors or accusing providers? Could it be payers coming out of the woodwork and accusing providers of making it difficult for them to get information? Are vendors going to just go into a war of attrition with one another? Exactly how that all plays out will really have an impact, obviously. And as we look at in general, what I see is a sort of gradual restructuring of the healthcare industry to work in a new IT context. Who wins, if you will, in some of that warfare is going to have an impact on what that emerging new system looks like.
Yeah, you know, stopping short of telling or recommending an app to a patient, maybe a health system compiles, what apps are we seeing? What are working best? Let's sort of say that so the patient doesn't get lost in this process. And yeah, I agree.
All right, very good. Let's go to our next question. Greg, we're going to start with you. What are some of the opportunities these new regulations present that you are most excited about? For example, will they enable us to better utilize technologies such as AI and predictive analytics to improve the patient care journey or clinical information flows?
Yeah, I expect that everything will go well with FHIR and API on an actual technical basis or a data flow. I don't think there's anything wrong with that. I think that can lend itself to more patient-generated health data, more social determinants of health data getting in and out of the system, so that could be good. I would love to see some value-based care models come out of this, if that is so. But to try and stick to the question here, it may not sound wildly exciting or innovative, but we did support ADT coming out of the CMS rule. This is admit, discharge, and transfer for hospitals, to start noting that. I think that is going to help the patient care journey. If we know where the patient is, you've got COVID patients, you've got fires out west, you've got hurricanes coming up in the southeast. Where is my patient? I think ADT is going to help, and we did support that. for hospitals to do so. That was within the CMS rule. I won't say it gets totally overlooked, but sometimes gets overlooked in the data to patients aspect of it. CMS did put ADT into that CMS rule. One final little thought on AI. Again, not a blockbuster, but CMS in its physician fee schedule proposed rule for 2021, they have proposed their first ever reimbursement CPT code payment for AI. And that's a real start. It's a total automated diagnostic. It's for retinopathy diabetes patients, really. A good start there. So you're seeing some movement, across the board here. But I think ADT is going to be helpful. Somewhat controversial, but I think ADT will be helpful in helping us round up patients or really do that care journey, as you put it.
Very good, Stan.
I'm hoping for big changes, and not necessarily fast changes, but a dramatic change. I'm really hoping this is the start of an opportunity for those who want to get to semantic interoperability, and probably my definition for that is that we can develop a third-party marketplace where applications can be created and they can be distributed and used any place where the standards are in place, where people are compliant to the standards. And it's the idea that you could have a group working on the best occult sepsis detection algorithm for the emergency room, or the best application for monitoring and tracking and managing heart failure, etc. And those things wouldn't need to be modified to know whether I was connected to Epic or Cerner or Allscripts or NextGen or whoever, so that it's a true open market. And we would see innovation and creation of things that we don't even think of now, in the same way that we see that with the internet today. Just things popping up that would be as innovative as Uber was when it first came out, and other kinds of things. And it moves those things to the cloud. You can imagine now that those applications, you could have one copy, and anybody in the world could access that and use it in an integrated way in the patient workflow. And it could be, you hope it would be part of a cycle of a learning health system, if you will, so that people are watching the outcomes from those algorithms and constantly improving them. And improving them means that everybody in the world can take advantage of that improvement. And so in my fantasies and my visionary future, we're sharing knowledge as executable programs, rather than sharing knowledge by publish them in a journal that a physician then has to read and then has to know how to apply. You have, if you will, ready to use. You just have to install and integrate. And so I'm excited, and that's not going to happen next week. But I really think the combination of the improvement in technology and these improvements in policy and regulation heralded an entirely new era, similar to when the printing press was created, invented. So I'm incredible, idealistically optimistic and unrealistically optimistic, but I'm hoping for a huge change in the way that health IT works and in the quality of care that we can provide to our patients. I think this is the start of it.
Dave, what's your optimism level?
My optimism level overall is pretty high. but it's tempered a bit by what I think the timeframes are going to be that's involved. I think I'm pretty well aligned with what Stan was saying there, where the rules primarily are enablers rather than being sort of directly transformational in themselves, and that's wonderful. That's perhaps we don't want to get into a political conversation, but that's one of the best forms of government intervention, is as an enabler that then allows the market forces to take over. But along those lines, I think it's going to take time. And what we're seeing is akin to the development of the internet in the 90s, which led to an explosion of new functionality in the following decade that obviously continues now. I think that's reasonable to expect, that what we'll see is a steady evolution over the next 10, even 20 years, where we won't necessarily say, wow, do you remember that crazy period between 2021 and 2023 when everything changed? I think more we'll look back in 20 years and all of a sudden look around and realize we have no idea even where we are from the standpoint of 2020, because things are so fundamentally different.
Mm-hmm. I would add, if I could, in context to what Dave is saying, the Cures Act was passed in 2016. It took us until 2020 to get an authored regulation on information blocking. And again, to his point, the data set that will be granted to patients beginning in November is the same data set you would grant to patients for the next 24 months before it grows to include other data types. So it'll be a long term. Yep. Maybe, as Stan says, but the innovation is going to come in during that time around the app market. That would be great.
All right, very good. Next question, Stan, we're going to start with you. What are the infrastructure needs related to interoperability that you are considering to support patients outside the hospital or clinic setting and to capture data from all relevant healthcare-related encounters?
I'm not an expert in this part. There are a couple of things that I would say, and some of it's directly relevant to Philips and things that we're doing with Philips. A lot of this has to do with, remote patient monitoring and collecting, getting data from devices. I mean, we're seeing that. I have sleep apnea, so my data has been going to the cloud from my CPAP machine now for several years, and I can go in and I can see how many apnea spells I'm having, and how sleep deprived I am. Not based on the sleep apnea, but I just don't go to bed soon enough.
Mm-hmm.
I mean, I think it's fascinating, and that's going to evolve and is already evolving, and Greg already mentioned it, more of the hospital at home sort of activity, so that it becomes smarter and smarter over time, so that it's not just a collection of data, but you have smart apps that are looking at the data, watching for when the right opportunity to intervene or guide the patient, interact and train the patient, all of those things. And we're looking towards that. And COVID has been a real motivator for change in this regard. I'm getting old enough that I consume more healthcare than I provide. So I've been through several either phone or video visits rather than going into the clinic and doing things. And I have to say it's great, because unless I need somebody to physically examine me, most everything else that happens at a visit you can do by video or by just talking about what my symptoms are, whether I need a medication change, all of that sort of stuff. And I don't wait in the waiting room. It's got to be more convenient for the physicians as well, because they can just be there and have much more control and orchestration of their day. And so yeah, those are some things that we're working on. Working on the remote patient monitoring and looking forward to the evolution of that to sort of true, hospital at home or hospice at home, or an integration of that, and looking at it as a comprehensive whole, rather than just rather than thinking about those things as in different databases or different architectures or different things, that it all needs to be part of interoperability, and the sharing of that information and the opening up of that information so that all care providers can see and access and use, and the patients can see and access and use all of the data that's most relevant to their care.
Yep, very good. Greg?
Well, I would envision a similar scenario that a patient is having a live AV telehealth visit. The provider can see longitudinal record. Could they also see real-time RPM data to act upon? Could there be an element of analytics plugged into that so that you have a complete remote visit equal to that of an office visit, not only in reimbursement, but in levels of data being seen and cared for? I would totally agree with that. As a policy walk, I would say there is some movement there also to get reimbursement around RPM to be bumped up in federally qualified health centers, rural health centers, CMS home health agencies, because home can mean a lot of different things to a lot of different people. I'm at home, I just got discharged, but I need some monitoring. Oops, I'm in a CMS HHA, I'm in a home health agency, and I need another level of care. So can we equate the technology feed, so to speak, or what a remote visit can really be, and is it a dashboard approach, things like that. But yeah, right there with you on where that needs to go. And if these regulations and rules are in turn empowering patients to get that data and have that data on them, maybe so much the better as we go through with as Stan says, that sort of app, bi-directional app language or communication.
Dave?
Yeah, I mean, I'll continue to love that. I agree completely with what Stan and Greg has said. I think, I had my first remote visit with a physician during the COVID-19 experience here, and it worked fine, and it was great. I didn't have to drive for 45 minutes to get there and 45 minutes back and sit in the waiting room and all those other things. And I'm sure, as Stan said, the physician had benefits from it as well. I think it's going to be really interesting to see how much of the move towards remoteness, if you will, not just in healthcare, but in society as a whole, ends up surviving post-COVID. I suspect that obviously in some ways we're going to revert significantly, but in others, I think there's probably some permanent change here. And I strongly suspect that the advancements in telemedicine and other just remote offerings in healthcare are here to stay for sure. That they moved up maybe to a new curve, part of the curve where they're going to continue to grow at a slower rate, but that big jump that they took is not going to go away. And there's a lot of different options there that health systems may have. It can probably be a double-edged sword depending on how you look at it. But from Carequality's perspective, we aren't directly investing in infrastructure or otherwise supporting these elements directly. What we're doing is trying to remove barriers really from interoperability, kind of like how I described the rules. We're trying to be an enabler so that as you in the health system perspective are implementing your strategies around remote monitoring, telemedicine, perhaps teleradiology, where you keep the physical hardware that performs the tests and maintain revenue streams in that way, but perhaps don't even have to have radiologists on staff, or maybe you supply the radiologists for others, depending on where you fit into the whole picture. There's all sorts of options there, but they only work if the systems involved can actually talk to each other. Despite whatever aspirations folks like Epic and Cerner and Allscripts may have, they're not going to run everything. and you are going to need to have these different systems talking with one another, and obviously you know that, and that's not going to go away in teleradiology. So the more that we can make that seamless, the more that we can remove those barriers, the more that we free everyone up to get creative about how they continue to explore these models.
You know, I would just,
all right, go ahead.
Just respond to that too. This is a tangent, so you can stop me if you want, Anthony. But
never, I never would.
Yeah. You know, the whole thing is sort of caused me and many others to reconsider. You know, when do we need to be face to face? When do we need to be together in a group? You know, that kind of decision for me is, you know, what do I need to be face to face in HL7 meetings, in LOINC meetings, in, you know, if I participate in the Carequality, when do I need to be there in person? And I think the information exchange, it works just as well. But what I worry about right now is when I need to create new relationships, because so much of what we do really depends on personal relationships and trust. And I'm not sure, you know, and that actually usually happens not during the formal part of meetings, but in the hallways, or, you know, at cookie break at HL7, or meals in the evening, or, you know, just other kinds of things. And that relationship development, I think we're going to have to figure out how we can do that remotely, or maybe we just decide that we still have to do that in person. But it's interesting to think about it, and how this can change those kind of things too. You know, national meetings of all kinds, AMIA, HL7, you know, HIMSS, all of those things. I think it'll never be the same. I'm not sure exactly how it'll be in the future, but I think it will never be exactly the same because of this remote experience.
Side note, Anthony, if I could, on trust and new relationships, buried, as Stan says, in the many pages of the information blocking regulation is a passage that says if a competitive vendor comes to you wanting your patient data for a legitimate research project, you must work that out, or you could be an information blocker. So a lot to take in there too, on as you say, where we'll start to embrace each other.
All right, very good. We're going to throw out our audience poll here, because I'm going to get a real kick out of this, and I want to see how people answer. And our panelists can answer too. Now, the key word here is admirable, right? Admirable. The healthcare industry has made admirable progress towards improved interoperability over the last 3 years. So let's answer that. Everybody answer that. Admirable progress. And we'll see, we'll get back to that in a moment. Got an audience question I want to throw out there. Is the current client-server medical records architecture the correct architecture to develop this high level of interoperability? The high risk of intrusion and ransomware gives CIOs sleepless nights. Who wants to jump on that? Greg, I see you. You look eager. Greg, why don't you jump on? See, you can see things. You may not be able to have a cookie break, which I love how you cited, Stan, but I can see Greg's eager. So Greg, jump on that.
Oh, I am eager to hear what Stan has to say on this.
Oh, I like that. He's kicking it over. What do you think? Stan, you want to take this one? Go ahead.
I missed the first part of the question.
Okay, it's technical. It's a technical question. Is the current client-server medical record architecture the correct one to develop this high level of interoperability? The high risk of intrusion and ransomware gives CIOs sleepless nights.
Oh, boy.
So too technical?
No, I think it's the right architecture. I don't see an alternative, I guess. I don't see a workable alternative. So I think we just have to figure out how to challenge those problems. and I'm not sure. Well, I'm taken a little off guard because I don't. In some ways, it seems to me that there might be a role for government there. Providing for the common defense. I mean, going clear back to the Constitution, I'm not sure we've taken electronic injury and damage to heart in the same way that we do, the normal military kind of conflicts and things. I mean, every other day we're hearing about somebody who has been attacked and whose system is down because of a ransomware attack or because of a disclosure. And it seems to me that there could be a role for the government to do something more about that, because I mean it's one thing that people are attacked, but then it really is alarming that people are paying the ransoms, and it's because, and they're not doing it. They're doing it because that's the fastest way to get back to business and to do what they need to do. So it's an incredible challenge, but it seems to me that people smarter than me, there must be fundamental ways to do better tracing so that people can't anonymously, attack a system, collect the ransom, and nobody knows who they are or where they are. It seems to me that there has to be better technical solutions than what we've come to so far, and we need to invest in it, probably on the scale, to start thinking about it on the same scale as we do, physical attacks, because I think they can be just as damaging and just as harmful to the country as physical intrusions.
Dave, go ahead. I'll add.
Yeah, I was just going to say, I agree with the direction that Stan's suggesting there. I think expecting that there will not somehow, whether they're hosted by a health system directly or they're hosted somewhere else, for the foreseeable future, there are going to be big pots of data that are going to be very tempting for those who wish to take advantage of them criminally. It just is what it is. There are a few things we may be able to do about that. There may be some interesting things that could be done to somehow make that information less valuable. I'm not exactly sure what that might look like, but that's one angle. And certainly I agree with Stan that developing greater defensive infrastructure, I hesitate to call it defense infrastructure per se, but defensive infrastructure, wherever that ends up falling in terms of who's responsible for it, I think is going to end up being really important. But to the basis of the question, I don't think that there's a problem necessarily with a client-server architecture, or that there's anything that we're going to see in the short term that really is going to be better in terms of providing a smaller target perhaps for these types of attacks. So it's something that is just part of reality, unfortunately, and it probably doesn't make anybody sleep any better at night. But focusing on how we can defend ourselves and how we can mitigate the risk as much as possible is certainly a way to go.
Yeah, and I certainly wanted your two takes on client-server architecture more than mine, and to really get back to the questioner and what they're looking for. I would only add that Congress has had a very hard time with its privacy and security bills of getting together and getting legislation moved. Would also just note that the information blocking regulation, we talk a lot about that it also carries with it a whole new host of certification updates that vendors need to look at also. Some privacy and security aspects there too. Not saying a real answer or a real solution, but agree, Stan, that via ONC certification, via Congress, it has to come out of there, I think, more than industry innovation, so to speak.
All right. So before we get back to our reveal our audience poll, I want to get our panelists to guess at the results. So, Dave, let's start with you. What percentage agree with this statement?
I'm gonna say 55% agree.
55. Greg?
35.
35. Stan?
Oh, I'll split the difference. I'll say 45.
45. Well, splitting the difference makes a lot of sense because the answer is 46%. Well done, Stan. Well done.
As always.
Very excellent. Excellent job. All right. Now we're going to do our Ask a Co-Panelist. Greg, I'm going to give you an opportunity to ask one or both of your co-panelists a question.
I guess, Dr. Huff, we haven't talked about it yet in this setting, but if you wouldn't mind giving us an overview of Logica Health, and the real question is, how can we help that effort, get it out in the world, or help you get Logica Health in front of ONC, well, what have you?
Yeah, no. For those who don't know, Logica Health is a not-for-profit charitable organization that was formed back in 2014. Intermountain Healthcare worked with the VA and with Louisiana State University Health, and the purpose is to sort of get to the vision that I described a little earlier, an open ecosystem, standards-based, interoperable ecosystem where we can share applications and services in a truly open market. And the short answer is you can join Logica, and we would love that. Logica, is focused on several different areas. One is how do we set the platform up so that we have the actual infrastructure to do the sharing. Another part is specializing beyond the US CDI. The US CDI is incredibly valuable and useful. It doesn't take you to the level of semantic interoperability, and so Logica is spending a lot of time saying, this is sort of exactly how you represent data in FHIR with the appropriate LOINC codes and units of measure and other things, and so we're doing a lot there. Logica is trying to think how we can do things more at scale. Sort of true interoperability is one analogy, is being the first person with a phone. You've got nobody to call. You have to create a community before there's value there, and so it's a bit of a chicken and an egg thing, and so Intermountain is working. There's another group called Graphite that's being led by Reese Robinson from Presbyterian Health, and working with Intermountain and Presbyterian, trying to look at ways that we could scale this and make it real. And so I'm excited about that opportunity. I think in terms of what we want to do, our vision hasn't changed. But what we do need to do is we need to get more people in town with a phone so that there's more value to interoperability at a practical level. And again, I can't say how much, I can't overstate, I think, the eventual value that will have to patients and to healthcare and to public health, et cetera.
I'll ask
So
Dave,
join.
if you don't mind. Appreciate that. Yeah, on our list. If you don't mind, Anthony, I'll ask Dave if patient matching. Do we need a unique patient identifier? Is patient matching still? I know it's just a
Yeah, I mean, sorry, go ahead, Greg.
The networks and Carequality, Commonwealth are collaborating, doing so much. Developing FHIR, is patient matching still just the fly in one for you guys, or can FHIR overcome that?
It's a real issue. You know, I've used an analogy before that we're building this incredible, you know, Ferrari-like automobile on a rusty grocery cart chassis because it's all based on this demographics-based patient matching, which you could pour all kinds of effort and energy into it, and you're only after a certain point going to be able to improve it incrementally. So I do think that we need something fundamentally different. A unique healthcare ID would arguably over time, once it was fully adopted, go a long way towards solving that problem. I think there are political and cultural barriers there that just probably make it unrealistic. Whereas instead of focusing on an ID number, focusing instead on some sort of healthcare identity that is you know, probably tied to your phone, may not get universally to everyone in the population, but gets a long way there, and over time does become more universal. As even the oldest among us have smartphones and these types of ability to carry a digital presence with us, if you will, and identify us. I think it'll be interesting to see what happens with COVID actually towards spurring on the adoption of such a voluntary solution. If you are required to, quote, show your papers relative to COVID status, for example, at some point, whether that's to even get into your job site or to get into the concert that you want to go to, or an NFL game, or whatever the case may be, get into a museum, any place that's out in the public where you may need to at some point prove that you're safe, offers an opportunity for this type of identity to be developed. And obviously we can look at that and see it as a negative, and there are ways that it could become a negative. But there are other ways where if that's channeled correctly and there's collaboration within the health IT world to really take advantage of that and leverage the fact that these sorts of capabilities are starting to exist, and also help them evolve in rational ways, I think you could see some voluntarily identified healthcare identity starting to be established and be used in the mainstream.
Yeah, I just comment on that if I could. I couldn't agree more with many of the things you said there. I just emphasize a couple of things. One is, you know, ONC has been working, you know, one of their FAST, that FHIR, FAST is like fire, acceleration, implementation. So anyway, can't remember what FAST stands for, but what it's about is trying to get FHIR implemented more quickly. And one aspect of that was about patient identification. And I learned some things that make a lot of sense to me. You know, healthcare shouldn't do this alone. And to a great extent, you know, the Visa card, MasterCard, you know, Discover card, they're in the business of identifying people and for purposes of financial transactions, and there are probably things that we can learn there. That probably the biggest thing I would say is what you mentioned, Dave, which is that the last mile kind of problem is not technical. It is societal and policy and bias and other things. You know, the people that we have the most trouble identifying aren't the people who have health insurance, aren't the people who have Medicare and Medicaid. We identify those at almost near 100% accuracy. We don't identify children, you know, newborns and early age that, you know, where their record at Intermountain starts out as, you know, baby boy Mary Robinson, you know, or something like that. And then the name transitions to a real name. and then the people who are undocumented aliens, people who have some kind of problem with the law. So the people that cause us to continue to have, between a 5 and 15% error rate in identifying people are people who are either children or people who don't really want to be identified because they're in fear of the social or criminal or deportation implications of being identified. And somehow we have to think about that, those political and social issues related to identity as much as we think about the technical reliability of identity.
Greg, I'm going to give you an opportunity for a final thought. You can address anything you want. I'm thinking of the Cures Act and the deadlines, but you're a policy wonk, right? So anything you want to tell people that they may, something in the fine print they may have missed?
Yeah, I will go back to the information blocking regulation because, again, you're looking at a November 2nd timeline to begin offering this USCDI. Identify the USCDI, identify these data elements, and run the exercise. Let's compile them. Let's put them together. Is it all in our EHR? Do we have to query out to an HIE? How do we even get it and pull it together? And then look toward, if we're going to stand up our own FHIR server, I think that's a pretty big heft, that health systems don't have to use their vendor's FHIR app. They can set up their own FHIR server. But go through the exercise of putting together the USCDI and just compile it and go through that exercise ahead of time. See if you have to query out. Do you have to query Dave Cassel to find a piece of where this data lies?
All right, very good. That's about all we had time for today. We do have a post-event survey that should open when you close your Zoom window. The chat the URL's also just been sent out in the chat box. So it's a quick 4-question survey. If you take a minute and answer that, we'd appreciate it. Regarding continuing education, you could use the final slide in this deck for your certificate. You'll get an email when the archive of this event is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy from our team, and you could go to our website to register for upcoming webinars. With that, as a tremendous conversation today, I want to very much thank Dr. Stan Huff, who mentioned both the Constitution and cookie breaks, and that hasn't happened in a long time. I want to thank Dave Cassel and Greg Fulton, and I want to thank Philips very much for sponsoring this event and you, our attendees. And with that, everybody have a wonderful day. Thank you.
Thanks, Anthony.